Good afternoon. I am Dr. Jacqueline CHUNG from the Department of ONG, the IVF unit of the Chinese University of Hong Kong. Thank you all for joining this TASTE lecture of our master course in reproductive medicine and clinical embryology. I'm very here today to have Professor QUENBY with us to give this talk on related to recurrent miscarriage. And we are very delighted to have her here. Professor QUENBY is a clinical academic widely recognized as a world leader in miscarriage and also preterm birth research. She had led highly cited Lancet series in 2021 that has changed the direction of miscarriage care and also research. She was a co-applicant and major recruiter to and co-author on the two largest and also most significant trials of progesterone for miscarriage prevention, PROMISE and also PRISM, and leading to NICE guideline changes. She is the director of the Biomedical Research Unit in the Reproductive Health, professor of obstetric and also University of Warwick, honorary consultant at the University Hospital Coventry and Warwickshire NSX Trust, and also the deputy director of the Tommy's National Center for Miscarriage Research and the co-director for the Center of Early Life and lead clinical advisors to the Kali Lilly Clinical Care. And we're so happy to have her here today. And we have prepared a strong welcome gift and to just to start off with the as a start.
Oh, thank you. Thank you very much. Thank you.
So our webinar series today will be, we will be having three lectures. I will start off with the first one and followed by David and then Professor QUENBY. So let's take start for the first lecture today. So I'm very happy here today to talk about this controversial topic on whether or not we should perform egg freezing in young women. So first of all, let me explain why we need it. Women are born with a finite pool of eggs that decreases throughout their reproductive years, with fewer than 1,000 eggs remaining during the onset of menopause. And as women progress towards the age of menopause, the likelihood of achieving a pregnancy in each menstrual cycle, known as the fecundity, decreases. And this decline is particularly notable after the age of 35. And one contributing factor to this decrease is also related to the occurrence of the aneuploidy in the older oocytes, which further elevates the risk of miscarriage as well. In the past, egg freezing was mainly used for medical indications, such like fertility preservation for cancer patients, especially if they are single, and also if they have adequate time for ovarian stimulation. Most of the time, we're talking about breast cancer. And because usually after the diagnosis and also breast surgery, patients have around 4 to 6 weeks time before they start their chemotherapy. And as majority of the chemotherapeutic agents that they use had a very high risk of ovarian failure. And so the patients can use this time to undergo oocyte freezing. But of course, other malignant cancer that requires chemotherapy, that requires alkylating agents, are also indicated for fertility preservation. Other indications are those who will be undergoing pelvic radiation, those who will undergo bone marrow transplantation. Apart from fertility preservation for malignant causes, other medical conditions, just like severe endometriosis, those with a high risk of having premature ovarian failure due to the need of ovarian surgery or due to genetic or autoimmune diseases should also consider it. As you can see in the social media, more and more women, including celebrities, have admitted to preserve their eggs as a fertility insurance for future use. Even So the freezing of oocytes have now become a clinical viable option for women who wish to have a child in the future, but are facing with either a age-related or erogenic decrease in the quality and also quantity of oocytes. It was in the past performed mainly for women with oocyte donation and those who do not have sperm available on the day of oocyte retrieval, and also for religious reasons. And now it's increasingly used for non-medical reason, what we call social freezing or elective freezing. Nowadays, there are women who wish to delay motherhood. For example, they want to focus on career development, or they can't find a suitable partner yet, or just waiting for financial stability before they start a family, or simply who they just don't feel ready for a baby yet. And oocyte cryopreservation has actually given the woman the ability to make reproductive choices. And they can allow them to decide when and also with whom they wish to have the children with. And it has also been described as a breakthrough for reproductive autonomy. Women are no longer restricted by the reproductive biological clock. And it is just like a fertility insurance policy. And many large companies like Google, Facebook, and also Apple has provided financial cover for their staff to undergo egg freezing in order to let their staff focus on their career. So ladies, maybe it's time to stop rushing to find a husband, but instead start rushing to freeze your eggs. Egg freezing is often promoted as a mean for women as a way to have it all. So that is like to have both a family and also a career. It suggests that by preserving their eggs, women can potentially have the option to fulfill both aspirations simultaneously. Indeed, according to a previous unpublished data survey performed by me and also the Hong Kong Society for Reproductive Medicine, looking at the trend of oocyte freezing among several Hong Kong IVF centers, the number of egg freezing for social reasons have been increasingly dramatically over the past few years. So how is it done? Okay, as shown in this diagram, oocyte freezing is similar to the usual initial steps of embryo cryopreservation as we usually perform for IVF. Basically, in women who have adequate time for ovarian stimulation, gonadotrophin, some hormones are used given for 8 to 12 days during the early follicular phase of their period to stimulate the ovaries to create a certain number of eggs, on average around 8 to 10 eggs per cycle. When majority of these eggs are matured, a transvaginal egg retrieval is performed. Instead of performing IVF to create embryos, these unfertilized eggs are then frozen for future use. But problems do exist with oocyte freezing. Historically, the overall success with respect to oocyte survival, fertilization, and also pregnancy rates has been low and has only been recently improved. This is because oocytes are known to be notoriously difficult to cryopreserve. This is because the oocyte is the largest cell in the body. It has a lot of water content. So during the freezing, it has a high susceptibility to have ice formation inside the cell and leading to damage to the oocyte quality. And it has a delicate and active mitotic spindle structure inside. And so freezing these eggs has a negative effect on these tubules. And in addition, after freezing of the egg, it will harden the shell of the egg, which we call the zonar hardening, where the shells are hardened and it is more difficult for the sperm to swim to fertilize the egg, and therefore leading to low fertilization rate of these eggs. And it requires special expertise for freezing and also a reliable protocol. In the past, oocytes were frozen using the controlled slow freezing method, in which David will be telling you more in the next lecture. Basically, slow freezing is using a low concentration of cryoprotective agents, and the eggs are then cooled at a very slow rate of around 0.3 to 0.5 degrees per minute. But during this procedure, there is a very high risk of ice crystal formation. And therefore, with this procedure, reported studies have reported very poor outcomes with survival rates after thawing with only up to 40 to 60%. Nowadays, vitrification has taken over slow freezing. And this process of cryopreservation uses initial high concentration of cryoprotectants. And with the ultra rapid cooling technique, it solidifies the cell into a glass-like state without the formation of any ice. And this led to better outcomes with higher survival rate after thawing and up to around 90% in some units. Currently, studies have shown that vitrified oocytes are just as good as fresh oocytes with similar outcomes. And it has been seen that the IVF using vitrified warm oocytes when compared to fresh oocytes did not differ in terms of fertilization, embryo cleavage, high quality embryo, or clinical pregnancy rate. The oocyte survival rates are now over 80%, and the clinical pregnancy rate per transfer is up to 60%. Therefore, the Human Fertilization and Embryology Authority allowed the use of frozen oocytes for infertility treatment in 2000, and the ASRM and ESHRI has lifted the experimental label in 2012 and 2013 respectively. Together with the development of intracytoplasmic sperm injection, in which we directly use one sperm and inject it into one egg, and also together with this vitrification method, has led to higher survival and also fertilization and pregnancy rate. And currently, worldwide, more than 1,000 live births has been born. However, are there any regulations in Hong Kong? Well, in Hong Kong, all the IVF procedures and also egg freezing are regulated by the Code of Practice provided by the Council on Human Reproductive Technology. Women can freeze their egg when they are single, but when they want to use it, they must be legally married and with the use of assisted reproductive treatment. And currently, the storage duration is 10 years or up to 55 years if it is a medically cancer case. And also for using these eggs, if it is a cancer case, these eggs can only be used when the patient has sufficiently recovered from the illness or cancer. And appropriate timing is a matter of clinical judgment with the appropriate expertise. And the arrangement to bring about a posthumous child in Hong Kong is not allowed. So what else to consider? What about the efficacy? Well, it has been shown that the optimal number and also the age to freeze egg currently is still very controversial. And around 15 to 20 vitrified eggs are required to achieve a live birth, around 70 to 80% to have a live birth, okay? And this is because the live birth rate per vitrified oocyte is only around 7%, even with the most experienced team. And as I mentioned, we usually have only around 8 to 12 eggs per cycle. So in order to reach the number of 15 to 20 eggs, then we will need more than one cycle of treatment. And every unit is different, and there's various success rate with different centers. And that is why in egg freezing, we should not give a false hope to the patient and lead them to have a false sense of security. Because even with egg freezing, it does not guarantee a successful future pregnancy. The most important thing to think about when you do egg freezing is the woman's age. It's not the age of the woman when the embryo goes back to the body that's crucial, but rather at the time when the age when she collects the egg. Of course, for quality, freezing the egg as early as possible is the best. But don't forget, in Hong Kong, we do have a restriction and the storage duration of only up to 10 years. So in case we freeze them too early, we might not have a chance to use them. So for example, the best time that if you want to get the ideal quality of eggs, you should do it around the age of 20 years to 30 years old. But a lot of women at that time, they may not be financially stable enough and to do it because the egg freezing is quite expensive in Hong Kong. And Therefore, freezing the egg too early and too late is not useful. For example, a 20-year-old woman who freezes her egg will have to use them by the age of 30. And at that time, maybe a lot of women at this age may not think about pregnancy yet. So previous studies have shown that it is not actually, the usage rate is still very low, and the usage rate is only less than 10%. And only half of them has considered using them in the future. So actually, a lot of these eggs are still being unused over the years, and it may be a waste of resources. So also, what about the safety side? Is it safe? Well, egg freezing is not without risk. The patient may suffer from the risk related to ovarian stimulation. She may have pain, bruising, soreness, or allergic reaction during the hormonal injection. And also there is a risk of ovarian hyperstimulation syndrome during the egg stimulation process, and which in severe cases can cause thromboembolism, ascites that may require abdominal tapping or even respiratory distress. And also, although the egg retrieval is a very minor surgery, but still is related to a risk of bleeding, infection, and also a small chance of visceral injury. And in those cases where we are doing stimulation for cancer cases, during the ovarian stimulation, actually our level of estradiol is raised almost up to 10 to 15 times of those in the physiological level. And so this may lead to a regrowth of tumor cells, especially in hormone-sensitive cancer like breast cancer. And in addition, there is currently still a lacking of safety long-term data for offsprings that use the frozen egg at a later age. So we should think, there's also some studies suggesting that we should also think about the welfare of the future born child, as a childbearing at an older age is related with a lot of obstetric complications as well. So there are also negative psychosocial consequences of having to grow up with an older patient. So, but in fact, sometimes these risks are still small. And currently, even with OHSS, by using GnRH agonists and some special protocols, and also elective freezing of the embryos, actually OHSS can be almost completely avoidable. So we need to weigh the benefits and the risks. And also some argue that even with older parents, actually it has its advantages as well. For example, they are more stable in their relationship, and they're better financially, more financially better when compared to younger parents. Another factor that we need to consider is about the cost. In Hong Kong, egg freezing is still provided as a private service, and only occasionally subsidized in public medical cases, for example, in those with cancer conditions. And it is not cheap. It costs around $60,000 to $100,000 in some patients. And also, some patients may need at least more than one cycle to achieve the optimal number of eggs required. So this may also lead to problem of justice and also inequality, because those who are financially stable can afford it. But women may think differently and are willing to pay no matter how expensive it is, because this is the only method of fertility preservation in single women. And it acts as a clinical option for those who don't want to defer fertility at a later age. And it acts as a fertility insurance to buy her some more time so that she can feel free from her guilt. And it also allows a genetically biological own child in the future. So to some women, these are priceless and money can't buy them. On further thoughts, it may also act as a gender equalizer in the future. It enhances women's reproductive autonomy by enabling them to decide when and whom they wish to start a family yet. And it also gives them the time to divert their energy to other life goals like higher education and also career plans, and so that they can feel less guilty and they don't have to rush to start their family because of the biological clock pressure. And so, having said that, I think at the end, it is a joint decision with the patient, and each case should be handled individually. And also, for example, those with cancer, they have no choice but to do it. But for those non-medical reason, I think it's different. So there's a lot of important points that we should cover during the counseling. It is important that we don't to tell them that it is no longer experimental technology. We should freeze our eggs during young, but not too young, because of the restriction of the 10 years storage in Hong Kong. And they should be financially, physically, and also emotionally prepared for the procedure. And they might need to expect that one cycle is not enough. And we have to tell them that they should be realistic and it may not work in the future. So in conclusion, egg freezing remains a very controversial issue. Both medical and also non-medical reasons should be approached differently. And it's very important for us as clinicians to provide proper counseling and taken into the individual, this should be individualized, looking into the patient's age, her general health, relation status, and the patient's expectations, and also her individual circumstances. And also inform her about the possible implications of egg freezing, and also tell her to be realistic. We need to examine her individual beliefs, explore the reason, core beliefs, and also religion. And it's best that we perform a proper assessment of the ovarian reserve so that we can allow the patient to have an informed decision making. So after this talk, I'm not sure if you have changed your mind, and if you were the patient or if you were to freeze, whether you would freeze your eggs. And I hope and I gave you an overall about the pros and cons. So thank you. So thank you, and I will be passing it on to David now, who will be giving a talk on the pros and cons of egg freezing, the different types of egg freezing methods.
So thank you very much, Jacqueline CHUNG, for the presentation. So from the clinical side to the laboratory side, I think most of you are clinicians. So I don't want to put you into sleep instantly. So I will keep this very concise and very quick as well, and leave the rest of the time for Professor QUENBY to present her stunning work. So today I'm going to talk about the slow freezing and vitrification updates and trends in the ART. I'm going to talk about the freezing method, what type of tissue is going to be frozen in the ART lab, and what method is preferably using for specific tissue type. And then lastly, I'm going to go through the literature. What is the evidence showing that which type of freezing method is better over? So in the ART lab, we usually deal with several types of tissue. The first is the sperm from male or testicular tissue. We will use slow freezing, as Jacqueline mentioned before, or vitrification. Both of the techniques can apply into these two kinds of tissue. And then from the female side, we've got oocyte, we've got embryo after the IVF treatment, and then possibly for the ovarian tissue, freezing for the women in the adolescence or cancer patients. So I don't want to make you embarrassing, Jacqueline, but actually two major types of control cryopreservation is predominant in the ART laboratory. One is the control rate freezing, and the other one is vitrification. But in between, we've got ultra rapid method. Actually, it's a mixture of the two different methods. So the control rate freezing is the slow freezing, can be applied on sperm tissue for both ovarian or testicular tissue. It was, at the very beginning, used at the embryo, mainly at the key phase stage, because by then, back then, the blastocyst culture was not very successful. That's why the using slow freezing on blastocysts were not very dominant by then. And then, of course, oocyte freezing can be used by the slow freezing. And the vitrification, we can do vitrification on sperm, but vitrification is not good at preserving the sperm motility. So it depends on the laboratory preferences. The sperm can be, still vitrified in the lab. The vitrification can be used for the ovarian or testicular tissue and embryo at all stages, no matter from the cleavage stage or the blastocyst. And of course, the vitrification can be used on oocyte as well. So let's go through some basic cryobiology. The main difficulty for cryopreserve a tissue or cell is because the water from the liquid stage to frozen state, the volume will increase. That's why we see the ice is floating on water rather than sink in the bottom. So that's why make very difficult to preserve the cells, because if the ice crystal formation is inside the cell, then it will damage the infrastructure of the cells and leading to the cell death. So the major challenges or major two prerequisites for cryobiology is reducing the water inside the cells or tissue and avoid the ice crystal formation inside the cells. So this is a very typical diagram that the temperature versus the concentration of the solution we use. So basically, we just need to avoid ice crystal formation at a very specific concentration between the temperature and the concentration of the solid. But the beauty of the slow freezing is using the intra and ultra cellular cryoprotectant in order to further dehydrate the cells, thus minimize the crystal formation inside the cells. But slow freezing doesn't really completely eliminate all of the ice crystal formation. That's why making the slow freezing technique, the survival rate is not as good as vitrification. On the other hand, vitrification just bypass all of the icing phase because of the high freezing rate, more than 2000 degrees per second. So it will not form any ice crystal during the freezing. So the slow freezing basically can be divided into three phases, from the room temperature to supercooling phase. And the second one is seeding. Seeding is the artificial introduction of the ice crystal formation, and then making the extracellular solid more concentrate, and then draw the water from the tissue, further dehydrate the cell or tissue, and then reduce the ice crystal formation chance inside the tissue or cells. And then in the last phase, after down to the -20 to 30 degrees Celsius, we can directly put the tissue into the liquid nitrogen and then for long-term storage. Normally, the control rate freezing, the slow freezing survival rate on embryo or oocyte, it's between 50% to 90%, depends on the lab protocol, because some of the lab have their refinement. So some of the lab are very good at slow freezing. They can, achieve the embryo survival rate up to 80%. But some of the, laboratory is less good at slow freezing. So that's why most of them switch into a more stable technique, is the vitrification. So the first frozen embryo transfer was successfully given live birth in 1984. So by then, slow freezing is predominantly technique used by IVF lab worldwide. And from oocyte, cleavage stage embryo, up to now is nearly 4 decades. However, in the middle of 90s, at the beginning of millennium, vitrification become a more popular technique inside the IVF lab because of the high survival rate. But now you think about the slow freezing is dying, but this is not true because the slow freezing is still the gold standard for sperm freezing and lately for the ovarian tissue and testicular tissue cryopreservation. So basically, this diagram shows you from the left-hand side to the right-hand side, the embryo to be frozen at key phase stage. At the very beginning, we put the embryo inside the equilibrium solution at the very beginning, and the cryoprotectant will diffuse into the cells. And then at the very beginning, the cell will be dehydrated. And then after a period of time, because of the cryoprotectant move into the cells, and then the cell will become equilibrium. And then the cell size will become normal. And then after that, under the sub-zero temperature, we artificially introduce the ice formation inside the sample. And then that's why the ice crystal formation will further dehydrate our sample to reduce the water content inside our sample. And then thus, by decreasing the temperature, finally, we can put the sample into the liquid nitrogen for long-term storage. So the ultra-rapid freezing method is a transition method actually by modifying, between the slow freezing and the vitrification. So basically incubate the embryo in a single solution for a short period of time and then directly plunge into the liquid nitrogen directly. And the ultra-rapid cooling method rely on a rapid warming protocol as well, because people from the experiment show that if you have a slow freezing, you need to a relatively slow warming procedure. But if you have a very rapid freezing procedure, then you need a very rapid warming for the survival of the samples. And the survival rate is comparable to slow freezing, but not as good as the vitrification. However, this method was not widely used in the ART lab. For the vitrification, it was developed in the 90s, and the first pregnancy was reported in 2000, and later saw a much higher survival rate from oocyte to blastocyst. So that's why vitrification become a very reliable technique in the IVF lab ever. But however, although vitrification seems perfect to preserve all type of samples, but for sperm, it is not very successful on preserving the motility. So if the sperm go through the vitrification, most of them will not motile. However, the viability remain the same as slow freezing. So basically, vitrification is a sample transferred in an equilibrium solution for 5 to 10 minutes under the hyperosmotic solution, and then further dehydrate into a vitrified medium containing high concentration of cryoprotectant and extracellular cryoprotectant to dehydrate the cell, and then directly put into the liquid nitrogen for cryopreservation. So when we compare the pros and cons of the slow freezing versus vitrification, the slow freezing, of course, is cheaper in long run. But however, the slow freezing machine is very expensive. That's why the setup cost is relatively high compared to vitrification. And other advantage of the slow freezing is less labor intensive, because if you vitrify, 10 embryos, then you need an embryologist to sit there for an hour to freeze off them. But slow freezing, after you put the embryo the samples inside the slow freezing machine, then you can just walk away and wait for the program to be done. For vitrification, the advantage is, of course, the lower setup cost, much higher survival rate, shorter run time, and the loss rate is lower because from time to time, you know, in the laboratory, we do lose some embryos. And the vitrification system, you know, will have less maintenance costs. For the disadvantage of the slow freezing, of course, as I mentioned before, is the machine is very expensive at the very beginning if you set up the slow freezing lab. And it needs a longer runtime, and the loss rate and the incidence rate is higher because, you know, the machine is quite complicated. When you put the samples in, there are lots of different type of incident will happen. For example, you drop the samples inside the machine, so you need to, you know, pick it up by opening up, and then if the seating is not correctly done, then the embryo survival rate will decrease as well. For the vitrification, the disadvantage, of course, is the ovarian tissue has fewer case on live birth, or bad for motility for the sperm cryopreservation. And it is a very labor-intensive activity. And of course, the consumable, including the holding sleeves or the of the consumables, reagents are expensive than slow freezing. So how about the clinical evidence between the slow freezing and the vitrification? So for the oocyte and embryo, there was a review in fertility and stability in 2020, clearly showing that vitrification, you know, has more is more efficient and survival rate in the in vitro fertilization treatment. But however, when I think because vitrification on preserving embryos or oocytes are quite obvious compared to the slow freezing. So that's why there are very little literature review talk about, you know, compare the slow freezing and the vitrification on oocyte cryopreservation. And the latest one was in 2014 in Cochrane Review. Surprisingly, in that particular paper, showing that there is no difference between the vitrification and slow freezing on the pregnancy outcome. So how about in the ovarian tissue? Surprisingly, although we've got quite a number of live birth from the slow freezing, I think it's up to now is more than 200 live birth from the slow freezing ovarian tissue. Compared to the vitrification, there are less than 20. But however, these two papers showing that there is no significant difference on the histological outcome or the gene expression profile, which indicated that maybe in the near future, the vitrification will catch up on the live birth rate compared to the slow freezing. So how about sperm and testicular tissue? Surprisingly, there is very few literature comparing the two methods on preserving sperm and the testicular tissue. Slow freezing is a better method to preserve motility of the sperm, while vitrification can preserve small quantity with high viability, but motility is compromised after vitrification. And vitrification on testicular tissue are still experimental only. There is no live birth evidence so far. So at the end, the take-home message is vitrification is currently the best method for oocyte and embryo freezing. For tissue, clinical evidence show no significant difference on preserving ovarian tissue between the two methods. Slow freezing is dominant in OVT at the moment. And for sperm freezing, to preserve motility, vitrification is not a good choice. And that's the end of my presentation. Thank you.
So thank you, David, for the excellent talk. And so we will be passing on to Professor QUENBY. As mentioned previously in our introduction, Professor QUENBY has a very strong research background in miscarriage. And so it is she is the ideal candidate to give us this talk on assessing the treatment and options for recurrent miscarriage. Welcome, Professor QUENBY.
So thank you very much for inviting me to Hong Kong. It's a really exciting city. So my name's Professor Siobhan QUENBY. I'm a professor at the University of Warwick, and I work clinically at University Hospitals Coventry and Warwickshire NHS Trust. And I've been working for 30 years on miscarriage, and I'm really passionate about it, which I'm sure you'll realise. So the key points of this lecture is to try and move away from the sort of traditional concept that 3 miscarriages is a serious condition called recurrent miscarriage, and 1 miscarriage doesn't matter. And I think it's now time to move away from that, and I'm trying to persuade you that that's the old-fashioned thinking. And after you've heard my lecture, you're going to agree with me, I hope, that every single miscarriage matters, and everybody who has a miscarriage does require some care. In lockdown, I had, just before our UK lockdown, I'd been invited to by the Lancet to write a series. So I managed to get lots of people around the world, and we spent a lot of months doing a literature review and systematic review of all the data. So I'm just going to show you some key points from all that work. It's important to realize how common miscarriage is. There's 23 million miscarriages every year worldwide. That means 44 pregnancy losses each minute. These miscarriages cause significant physical consequences. The woman suffers pain, bleeding, and an increased risk of infection. But probably more importantly, the main problem with miscarriage is the psychological problem. After miscarriage, you have an increased risk of anxiety, an increased risk of depression, and 9 months after miscarriage, you have a 25% risk of post-traumatic stress disorder. So whilst unfortunately the medical profession obviously think of miscarriage as something that doesn't matter, remember every patient you see, it often does matter. It's the loss of the hopes and dreams of having a baby. It's associated with significant mental health conditions. And that's one of my first most important reasons as to why every miscarriage matters. The next and most important reason is the basic epidemiology that is shown in this slide. You can see there's a J-shaped relationship between age and number of miscarriages, but there's also a stepwise increase in your miscarriage with each subsequent miscarriage. Notice there's not a sudden increase in your miscarriage risk when you've had 3 miscarriages. So if you've had no miscarriages before and it's your first pregnancy, you have 11% chance of miscarrying. If you've had 1 miscarriage before, that increases to 20%. So 1 miscarriage does increase the chance of your next pregnancy miscarrying. 2 miscarriages, it moves up to 30%, and 3 previous miscarriages up to 40%. See, this is a stepwise progression. This isn't a sudden thing defined by textbooks. This is real data. Now, this risk of miscarriage actually directly follows the risk of aneuploidy, as very eloquently shown by the first speaker. And as we all know, the older you are, the more likely you are to miscarry, largely because of increased risk of aneuploidy, or particularly in maternal oocytes. We also know that the more miscarriage you have, the more likely you are to lose normal pregnancies. But look at this graph. The grey is the loss of normal pregnancies, and the red is the loss of abnormal pregnancies. The grey is only bigger than the red when you're on your 5th or subsequent miscarriage. So artificial cutoff that the Europeans argue about whether it's 2 or 3 miscarriages is not a relevant argument, because it's actually very high order of magnitude of losses before actually it's more likely it is that you're losing normal than abnormal. So my first point is, one of the things that we need to think about of miscarriage, instead of just counting the number of miscarriages, which I'm going to suggest to you was something we should have done last century, this century we should say every miscarriage matters. And one of the things that does matter to the patients is the carrier type of the miscarriage. So one of my junior doctors has done a qualitative study. So a qualitative study means that you ask patients what they think. This was done in our UK lockdown, so it was done on Teams, on online recording, and they record what a group of patients think about miscarriage, then they analyze their thoughts and try and recognize themes. And our theme was that the patients did feel that knowing the karyotype of the miscarriage was really important, and that was constant across all the patients. What wasn't constant across all the patients was some people would want to know the sex of the pregnancy loss because it helped them bring closure, and that the doctors were recognizing that the doctors cared that they'd lost a baby or potential baby. But some of them didn't want to know the sex of the baby because they felt that made worse. So we found that you should ask the patients whether or not they want to know the sex of the baby before giving them the karyotype result. So this was done in the context of the NHS when we're allowed to get karyotype of miscarriage tissue on your third or subsequent miscarriage. Obviously, to people who are working in the field, the karyotype of the miscarriage is really important. It's important to be able to give couples a reason for their work, their loss. If you've given the patient a treatment to try and prevent miscarriage, it's important to understand if you've got a reason why it doesn't work. So if you've given a treatment for a miscarriage prevention, and in fact the woman miscarries, for example, a trisomy 15, you know that all pregnancies with trisomy 15 will miscarry. So the woman miscarried because the pregnancy wasn't normal, she didn't miscarry because there was something wrong with herself, and she didn't miscarry because the treatment didn't work. Also, it's very difficult to interpret the research literature in miscarriage when I explain to you that half of miscarriages are abnormal. So you will not prevent abnormal miscarriages, and so trying to see any additional benefit from treatment is hard work. So this is just some NHS data from our series. So this is a cohort study of 227 consecutive people who had attended the recurrent miscarriage clinic and then had miscarried again. And we wanted to see how good we were at giving people these results. Unfortunately, we were unable to get a result in 28% of the people. That's because we were unable to collect pregnancy tissue or villus tissue and get it to the lab in a state where they could analyze it. If we did get it to the lab in the state, they were very good at analyzing it because we had access to culture, array technology, and qPCR. So this is a clinical problem, and we found you're more likely to get a result if you had surgical rather than expectant management. But notice there's not such a huge difference between the three management methods. And of course, as I'm talking in the privilege of talking in Hong Kong, the major contribution to my field is from Hong Kong is NIPT. I'm sure you all know about this. And there was this interesting paper in the Lancet from a colleague called Henrietta Nielsen, who works in Denmark. And what she did in her miscarriage clinic was collected blood tests at the time of miscarriage for 1,000 patients, and found out whether or not it was possible to use NIPT to find out whether or not people were losing normal or abnormal pregnancies. Because like myself, she feels the future of miscarriage would be to say whether people are losing normal or abnormal, rather than having to go to a last century option of having to count the number of miscarriages, which is where we are now. And she found that even if you're miscarrying at only 5 weeks gestation, so you've only got a very small intrauterine sac, it is possible to find out the karyotype of the miscarriage by taking a blood test. The problem was you did have to take the blood test at the time of the miscarriage diagnosis. If you just waited 24 hours, the amount of cell-free DNA in the circulation was very low. So I'm really pleased to visit Hong Kong because I'm hoping you're going to help me with my campaign, since this is where NIPT was invented. So I'm very privileged. So the next issue I'm going to go on and talk about is recurrent miscarriage and thrombophilia. So we've always known there's an association between miscarriage and thrombophilia. So that means if you get a group of people with miscarriage and a group of people without miscarriage, more of them have an acquired or inherited thrombophilia. An acquired thrombophilia is called antiphospholipid syndrome, and inherited thrombophilia is usually point mutations illustrated in this slide. So inherited thrombophilia are factor V point mutations in the factor V Leiden gene, which can be heterozygous or homozygous, point mutations in the prothrombin gene, activating protein C resistance, antithrombin 3 deficiency, or protein S and protein C deficiency. And you can see these have all been strongly related to recurrent pregnancy loss. So many years ago, I set out to embark on a randomized controlled trial to find out whether giving patients low molecular weight heparin who had inherited thrombophilia would improve outcome. Because if inherited thrombophilia really is a cause of miscarriage, then preventing the thrombophilia with low molecular weight heparin should improve outcome. So this was the study design. Our inclusion criteria was people who had 2 previous miscarriages who then registered for the trial. Once they were pregnant, they were randomized to low molecular weight heparin or standard pregnancy surveillance. If you can imagine, this is a really difficult trial to go to, because you've had couples who've lost 2 pregnancies, you've found an inherited thrombophilia, and then you have to try and explain to them that we don't know whether or not low molecular weight heparin worked and that we would want to randomize them. So it was really difficult to get the number of patients required. So our power calculation said we needed to get 324 patients. So in order to do this, we had to use a lot of countries around the world. So we had sites in the UK, Netherlands, Slovenia, Canada, and North America. So because of that, we had to use whichever kind of low molecular weight heparin was most commonly used in that unit. And so it was a variety of different kinds of low molecular weight heparin. The most commonly used one in the trial was enoxaparin. So the way we ran the trial is we had 2 major sites. We had one in the UK led by myself and the other in the Netherlands, who coordinated the Netherlands and the other international sites. And amazingly, we did manage to randomize 326 people, but look how many years it took us. 212 to it really was a horrendous amount of work. And we did get stopped by the European sponsors, the European during the COVID pandemic, when we weren't allowed to randomize people. But we did get very good follow-up, and we did really good compliance. We unfortunately, in the standard care arm, 18 women did receive low molecular weight heparin before 12 weeks. But we got absolutely no difference in the live birth rate here. You can see that they're very, very similar, both statistically and just looking at the graph. We also had secondary outcome measures looking at other pregnancy complications and got absolutely no difference in the other pregnancy complications. And one of the criticisms of our trial is, don't the people with inherited thrombophilia who are on the standard care get thrombosis? No, not one single person got a thrombosis. Notice we did have one thrombosis, but that was in the low molecular weight care arm. So we have shown it is perfectly safe that if you have a history of recurrent miscarriage and inherited thrombophilia, you do not need to give the injections. It doesn't stop any pregnancy complications, and it's not necessary to prevent thrombosis. This is just to show you if we did a pre-specified subgroup analysis, it didn't help in any of the subgroups, and we did a re-analysis removing the 18 people who did have the low molecular heparin before 12 weeks in the standard care arm, no analysis. So I can confidently tell you that low molecular heparin does not increase the live birth rate. It is important to notice our live birth rate was only 70%, so there are more answers in miscarriage out there waiting to be discovered. Low molecular heparin did cause some harm. There was more bruising in the low molecular heparin group. So I do not recommend treating people with recurrent miscarriage and inherited thrombophilia low molecular heparin, and therefore I do not recommend testing them. I'm hoping that by stopping the testing and the treatment, that healthcare resources can be better spent on other uses. I think this trial is very important because it also means that miscarriage is not to do with excessive coagulation, and we need to look for other causes. So in the last series of the Lancet paper, we did look at what can you do. Having told you what you can't do, I'm now going to tell you what you can do to prevent miscarriage. Well, we identified 3 tests that were useful and possible treatments. We identified that testing people for hypothyroidism is useful because if you give thyroid replacement to keep their TSH in the normal range, that did prevent miscarriage. And there's strong evidence for that. We also identified that testing people for antiphospholipid syndrome was useful with anticardiolipin antibody and lupus anticoagulant tests, but there's only weak evidence of that. We identified that doing a 3D ultrasound scan of the pelvis to look for uterine abnormalities was useful, but unfortunately, randomized control trials have not shown that treating anomalies has helped. And we identified that testing people for balanced translocation, particularly if they'd lost unbalanced, genetically abnormal miscarriage, was useful. So prevention, we've got thyroxine, aspirin, and heparin. We also identified that if you have one previous miscarriage and bleeding in early pregnancy and you give progesterone, you increase the chance of someone having a live birth by 5%. If you have 3 previous miscarriages and bleeding in early pregnancy, progesterone increases the chance of having a baby by 15%. So if you do see people in your emergency services who've had a previous miscarriage and they've got bleeding in early pregnancy, and you give progesterone, you do increase the chance of having a baby by 5%. I think that's very valuable to the patient. And progesterone is not particularly a cheap, expensive treatment. So the last thing we wanted to do is radicalize the way we deliver the service in the light of this evidence. So as I've tried to explain to you, I think the old-fashioned idea of that you could only have any medical care if you've had 3 miscarriages is ridiculous and not acceptable in this day and age. When we wrote this final paper, we actually had a lot of input from our Tommy's charity, which is a patient group to represent patients. And at the same time as we were getting this published, they did an online campaign in the UK to ask to collect signatures to say that this concept of you having to wait 3 miscarriages before you could get any care in the UK wasn't acceptable. 260,000 people signed up to the campaign. So in the UK, that was brilliant, because if you have a campaign with more than 100,000 signatures, you get a debate in Parliament. So this was my good year. COVID was horrible, but I had a nice thing, and my nice thing was I got my paper in the Lancet, and we got this debated in Parliament, and the Minister of Health had to say in Parliament that you have to care about miscarriage. Unfortunately, not that much has changed, but at least my campaign works. So what am I expecting you to do after 1 miscarriage? So this is the evidence. These are the things that are associated with miscarriage. I think there are things we can do about. So we know that the body mass index is associated with a miscarriage and poor pregnancy outcomes. So if you see someone with their first miscarriage and high body mass index, they should optimize their weight. Similarly, they should reduce smoking, reduce alcohol. Some of the things are more difficult. It's difficult to reduce stress in your life, but there's sometimes options to take on a less stressful job than you are at the moment. Really controversially, talking to medical staff, is there is actually in the literature an association between shift working and miscarriage. So that means that I don't know what your shifts are like in our hospital, but in your hospital, but in our hospital, the junior doctors do 4 days. They do 12-hour shifts. So you do 4 lots of days or 4 lots of nights on a rotation. So you're constantly going from days to nights. So that is associated with miscarriage. So I think this is important. So I think if you keep miscarrying and you want a baby, I write letters to the hospital occupational health to say they should come off shifts. So I'm not very popular, but it's up to you as to how to interpret that data. Also, if you're on long-haul airplane flight worker, you can move to short haul. So you don't stop working. But I think it's very reasonable for women's job to be rotas to be done so they're most fertile. I would do. And so the other problem we had is this. And so I actually did a long-term cohort study. So I followed up 770 women who'd been in my current miscarriage clinic for 5 years to find out how good I was, because obviously I think I'm marvelous. And I was actually quite shocked at this data. So the green line is the number of people who actually have a baby, and the blue line is the number of people who got pregnant again. So you can see that actually after 2 years, 60% of people had a baby, which is good, but of course 40% didn't. So why are so many people not ending up with a baby despite repeatedly trying? I actually found that 20% never got pregnant again in my clinic. And I actually found a lot of this was voluntary infertility. So the most common reason you didn't get pregnant again, because you're absolutely terrified of not getting another pregnancy. This is when I realized 1 miscarriage matters. You know, that some people who've had 2 miscarriages, in our traditional medical teaching, it doesn't matter because they haven't had 3 miscarriages. Some of those are so frightened they will never get pregnant again. And this is really important. And we discovered this with another qualitative study with my research fellows. So in order to do something about this, I decided I'd go into digital healthcare, and I've embarked on a journey of trying to help this way. So I gave the same data to 2 very clever mathematicians who came up with a formula to predict your chance of pregnancy outcome. The things in the formula are age, BMI, polycystic ovaries, number of previous miscarriages, and history of previous live birth. Those were the things that are best at predicting your future pregnancy outcome. So this is how the formula works. So for example, if you're only age 20 and you've had one previous miscarriage and you've got a normal body mass index, you've got 80% chance of having a baby. Notice with each increasing miscarriage, you have a stepwise increase risk of further miscarriage, whatever your age. And this whole graph, as you can see, slips down with a high body mass index. So we got some funding and worked with app developer and lots of patients to try and make online thing, which I call the miscarriage support tool. As you can see, this can be on your smartphone. So what happens is you put your personal details in there and it gives you little messages like, so if you say you smoke, it gives you smoking cessation advice and how to stop smoking. If you've got a high BMI, it tells you how to lose weight and have a more healthy lifestyle. If you've had 3 miscarriages, it tells you that you are entitled to a consultant appointment. If you have bleeding in early pregnancy, it tells you to try and get some progesterone from the health service. So we had a big launch of this, and it has been a big success. Since November 2022, when we started, 110,000 people have used it, so I'm absolutely delighted. But that actually included 83,000 individual users. A lot of people used it twice, so they tried putting in a lower body mass index to see how much they'd improve it. Patients were brilliant. These people are actually all over the world, so this is why I'm warning you. I've done it. If you come out with you're also allowed to ask for online support emails. We ask them if we can store the data for further research. And if you have a very low body mass, a very low chance of future successful pregnancy, there is midwifery counselling for those specific people. We've got really good feedback from the tool. And so, we really are pleased. I do not think this is the best ever digital healthcare project there is. But what I'm trying to say is I think this is the answer. I totally appreciate that your healthcare resources will be limited as are ours, and it's not possible to offer extensive healthcare to everyone who has a miscarriage, but it is possible to use digital health to achieve that objective. So in conclusion, I'm hoping that I've persuaded you that every miscarriage matters, not just 3. Every miscarriage matters because it has mental health consequences. Every miscarriage is a time to improve your health. So it's to improve your health in terms of body mass index, smoking, making sure they're on folate. After 2 miscarriages, it's very reasonable to do full blood count and thyroid function tests. These are cheap tests and easily treatable. Also, think about every miscarriage, therefore, as not just an event waiting for a few more before we're going to do anything. Every miscarriage is a time to consider the next pregnancy and